Hello, I'm Professor Patrick McGorry. Welcome to today's webinar. Before we proceed, as Executive Director of Orygen, I would like to acknowledge the traditional custodians of the land on which we work around Australia and pay my respects to elders both past and present.
Welcome to today's webinar delivered by Orygen, the National Centre of Excellence in Youth Mental Health. My name is Carlo, and I'm a member of the Youth Research Council at Orygen. Today I'll be facilitating this webinar together with Rosie Purcell, Director of Research and Translation. The topic of today's webinar is what is knowledge translation and why is it important to youth mental health? From a young person perspective, research translation, knowledge translation is important because it empowers young people to understand what are the treatments that suits them best and also facilitate an alliance with the clinician. Now we'll move to the next slide. What is knowledge translation? In youth mental health, knowledge translation means using the research findings and transferring them to knowledge that is applied on the ground in clinical or practice services. Today, what we're looking with knowledge translation is how we're going to bridge the gap that in order to assist services and as well connect with young people to make sure that these practices are adapted to the context that we're focusing on. The purpose of this webinar will be to examine the research cycle, explore key concepts within knowledge translation, and examine the evidence for what knowledge translation methods work best in youth mental health. Now, I'll pass over to Rosie Purcell.
Great, thanks for that, Carlo. So I want to start just by talking about what the research cycle is, and then what we mean by knowledge transfer or knowledge translation, and some of the key concepts there and why they are so important in youth mental health. So this diagram shows a fairly standard research cycle where at the top in red we start with a question of interest, and then as we move around the circle there, we generate proposals. It misses one of the most important things on this slide, which is obtain funding or money to conduct the research. In green there you can see that we then have to obtain ethics approval, so we're doing research in a proper ethical way, particularly with young people and involving them as partners where we can in the research. Then in yellow you get to the point of actually conducting the research study, and the last point of that in purple is this dissemination and research translation. And that's what we'll focus a lot on today. You can see on this circle that it's meant to be continuous, that once we've disseminated the findings and translated that to our audience, whether it's service providers like yourself or young people and their families, that's then meant to stimulate more research. We've answered some questions and hopefully it's generated more. But unfortunately what we see often in practice is a study stops, we disseminate the results, and then that's it. And that's what research translation is really trying to stop, just that we've communicated results to one party. We want to really communicate this in a way that's meaningful to everyone who's involved. So just to pick up that theme a little bit more, you can see here for the top issue of dissemination, what usually happens is that researchers publish their findings in journals, and they're usually just looked at by other researchers and academics. So these are two examples here of fantastic studies actually looking at headspace. But if that's all we do, communicate the findings to one small group of the whole youth mental health population, researchers, then we're not really going to change practice in any way. So where we are with knowledge translation is a more detailed approach here, and it basically has three prongs, if you like. So the first one there you can see is knowledge synthesis. And this can be called evidence synthesis or research synthesis. For the purpose of today, we'll just focus on knowledge. But this is the first step where we try to collate all of the evidence that exists on a topic. And that's important that we're collecting as much evidence as possible and not restricting ourselves just to cherry picking some evidence, because then we might be introducing bias or not really covering all of the areas that need to be looked at for a particular issue. So knowledge synthesis is one thing. But then we get to the heart of it, which really is this knowledge translation. And that's where we take the findings from the evidence. Just get a pointer here. So we take what we've learnt from research studies, and knowledge translation is how do we apply this in a particular context or setting, and how do we take account of the preferences of young people or other end users. So it's not just being slaves to evidence, it's actually saying how do we use this in a meaningful way in my particular area or setting to improve outcomes and practice for young people. And then the third aspect of it is how do we implement that knowledge in practice. And essentially what evidence implementation is about is the how-to. How do we bring about change in practice based on that knowledge? And that's a major area of research and practice that we're not going to go into in today's webinar, but that will be a focus of some more work that Orygen is doing and communicating to yourselves. So I just want to pick up a little bit more of this difference between evidence synthesis and the knowledge translation. So let's look at an example here where study X has been conducted, and let's just say it's a rigorous cutting edge study, or it might be that we've synthesized a lot of the evidence in this particular field. Now, in this example, what we know from study X is we've got very strong results for young people who have been seeking help for mental health problems in large metropolitan areas or cities. And that's great. But what we're talking about then with knowledge translation is how do we take this and again adapt it to the context or the audience that's relevant to you, the clinician or service provider who's the beneficiary of this knowledge. So in this instance, it might be, well, how do we take the findings from study X and apply them to young people who live in rural or remote areas? Or what about young people who are not seeking help for their mental health issues? Can we use that evidence and apply it in that context? So that's what we mean about the difference between synthesis and translation. It's really how do we apply or adapt this in the area that is most relevant to your context, but also that takes account of the young person's preferences. A really good example of this in clinical practice is on this site. There's an enormous amount of evidence about cognitive behaviour therapy or CBT and how that works for example, depression. But knowledge translation is where we would be applying that in a particular context or area. So what happens if there's not clinical psychologists who can deliver that particular treatment? Or what if you have a very young client, let's say a 13-year-old boy, who's not in a position to feel comfortable about talking about his thoughts and analysing that? That's where we'd be trying to adapt what the evidence says, but is most useful in this particular context. So I want to spend the next few moments just really talking about what is research and why it's important in youth mental health. And I might bring Carlo back into this conversation as we go along as a member of Orygen's Youth Research Council, which is where we're using the experiences, the opinions, the preferences of young people to really help and guide us on this work. What is research? It's actually as simple as just asking questions, being curious about how we can do things better or why things are occurring, and then conducting a study of some kind to find the answer. So we don't have to complicate things. Research is really asking questions and trying to find answers. There are a number of different approaches to doing research studies, and it really will depend on what your question is as to what the best approach will be. So you can see there are some examples. Randomised controlled trials are used a lot in our area, and that's really testing one intervention against another. The question, though, may not lend itself to a randomised trial, so we might be conducting pre-post assessments. That might be where we don't have a control group, but we just want to know, well, is this practice or this treatment improving things for young people? So we can look at before and after there. Sometimes we might be at a really early stage of inquiry, and so it's not appropriate to go out and do a large study, but we might want to do more qualitative and in-depth interviews with either clinicians or with young people. So, for example, Orygen has only recently in the last few years set up its Youth Research Council. That's an example of where, rather than going out and surveying everyone in the field here, we might want to do some in-depth interviews with our members to find out what's working and what's not. Then we can do other things like surveys with large groups of people and even get into things like program evaluations. So it's important to keep in mind that research can look very different depending on what we're asking and what's going to be the best way to answer that question. Why we do this is to develop knowledge. And you can see there are just some examples of questions here, but they could be any number of issues that we want to understand. And for us, fundamentally, at Orygen, what we're trying to do is conduct research that helps us to understand why mental health issues affect some young people and not others, and what are the best treatments that we can develop and deliver to young people so we are improving their lives in a meaningful way. And can we develop new treatments if there are ones that don't seem to work at the moment?
Before, Rosie mentioned that the Youth Research Council members are providing useful insights to the research department at Orygen. And as a member of the Youth Research Council, what I can say is that young people bring a different perspective into the problem that the researchers are trying to solve, which is a very important thing when we're looking for answers. What's the best approach that we should have in this treatment? how can we engage more young people in that particular service. So from my perspective as a member of the Youth Research Council, we bring an input to the problem from a different lens, and that's why I think it's been very useful for both myself as a young person, but also the researchers at Orygen to deliver positive outcome to the research.
Thanks, Carlo. I think that's really important for us to keep in mind, that we might have a particular perspective on why we're doing research, but young people, either in guiding us or in participating in the research, will have different perspectives and different needs. And that's what we're getting to the heart at with research translation, that it's not just about what does the evidence show, but it's how do we apply this in a way that is meaningful for young people and takes into account their contextual issues, as well as the service providers' context in where they're doing this work. So there are a number of different places where you as service providers can find research evidence if you are curious and want to look at this yourself. There might be issues that you have in your practice that you think, I'd like to understand what the research says about this. And there are different ways that you can find that. Probably the best is here with Google Scholar, simply because it's freely accessible to almost everyone. So you can type in some information or the question, the issue that you have in mind, and Google Scholar will bring up at least the abstract of the study, so you can read through what's the summary of findings there. If you work in a hospital or a university setting, then some of these other resources might be freely accessible to you. PubMed has one of the largest repositories of evidence in the world. And again, if you don't have access to these through a university or a hospital, you can still look at PubMed and at least get the abstract of a study. This one's PsycInfo, and it focuses more so on psychological studies, and these other ones are looking at broadly medical research. So if you are curious, you can go out there and have a look for research evidence. But what's important is actually the quality of the evidence. So you might type into Google Scholar depression, pet therapy, and what you might get there is a lot of research, but how do you know, well, is this high quality or not? And that's where you do, as a consumer yourself, have to understand what is quality when we talk about knowledge or evidence. And in Australia, the National Health and Medical Research Council, or the NHMRC, has brought out some guidance around what are the highest levels of evidence and how do you appraise studies for their quality. So I won't necessarily go through all of the boxes here, but the hierarchy of evidence is the highest is at the top, going down to the lowest levels of evidence down the bottom. So the highest is a systematic review or a meta-analysis, which has pulled all of the available studies out there, and it hasn't limited the search in any way. So that's a high level of evidence, because you can be confident that all studies have been included, regardless of whether they're positive or negative. The next level down is doing a randomised controlled trial, and that's considered a high level of evidence because the participants have been randomised either to a treatment or a control condition. And that's important because it means there's an equal chance of landing in either group, And so there's not some bias that might be introduced by one particular population of young people, for example, all ending up in the treatment condition and a different group in another. And we go down to what it says here is the least strong form of evidence is if we're just looking at case studies or small populations. And that's not to say, again, that these studies aren't valuable. It will depend on the question that you're asking. But these are considered low levels because you might be introducing bias. You're not representing a whole group of young people. There might be something specific here that we find isn't going to apply across the board. So just keep in mind how we do the research depends on what question we're asking, but you can have a level of scrutiny that, well, okay, this study's been done on the topic that I'm interested in, depression and pet therapy, for example, but it's not very strong evidence if it's used this approach. So there's levels of evidence, but then here they talk about how we kind of do a broader appraisal of what that evidence means. And you can see it's referring to a body of evidence now rather than just one or two studies. And we usually use this if we're coming up with guidelines for practice. So you can see here and I have to put my own glasses on, that it's either rated as excellent, good, satisfactory, or poor. And the 5 components here are the important ones down the side here. So it's excellent if there's a large evidence base. There's lots of studies that have been conducted on this, not just 1 or 2. The evidence is consistent. So if the studies are all showing roughly a similar result, then that's better than if there's a lot of inconsistency and we say we don't really know what this evidence means because different studies are finding different outcomes. This third one is a really important issue, and that's the clinical impact. So often studies are done where we'll compare groups, for example, and there'll be a statistical difference between those groups, but it may have very little clinical impact. So, for example, we'll say there's a statistical difference that this treatment is better than no treatment at all, but when you actually look at it, it's maybe only 1 or 2 points different on a, let's say, a 20-point scale of anxiety severity. So that's where we'll look at, well, what does this actually clinically mean in practice? Is it going to improve outcomes for young people, or is this more just a statistical result? The fourth one is generalisability. So there might be research that's been conducted, but we can't apply this to other populations. It can only be applied to a particular group. And unfortunately, we do see this a lot with youth mental health research. So there might be studies where they haven't included young people who are non-English speaking or young people who have suicidal ideation or young people who are homeless might be excluded. And that's problematic because we can't generalise those results to the broader population. And definitely research has been guilty of doing this, of finding a result and then saying, well, we can apply this to everyone. And again, that's at the heart of research translation, taking that evidence and thinking, well, how do we apply it then to non-English speaking young people, called backgrounds, LGBTI. So this generalisability and the applicability, and in this context, it's can we use this in the Australian health setting? That's really important. So hopefully this little guide helps you that if you are ever curious at looking for some evidence, you can think, A, what's the level, what's the quality of the study that I'm reading, but B, this just gives you some tools to really scrutinise what you're looking at and make your own judgment on whether this is a strong body of evidence or not. Now, most service providers and clinicians don't have the time to do that, so that's part of our job here at Orygen, is to summarise and translate research for you. But we also have this evidence finder on our website, and you can see the URL down the bottom there. And what you can do is search through each of these terms, and you can see down the bottom that we're only including the highest levels of evidence, simply because there is a lot out there that we want to filter out for you, the studies that may not be particularly strong. So you might be curious about a young person with substance use conditions. This stage of illness is talking about are they experiencing a prolonged substance use disorder, or maybe they're just at risk. So the stage of illness is capturing that level. Are we talking about prevention, early intervention, relapse prevention? Or you might just want to search on a particular treatment type. Or you might even just want to plug in some keywords that you're curious on. Again, let's use the example of pet therapy. You can put that in here and it will show you the evidence. And the crucial part here is it will show you the evidence for research in young people. So this has filtered out anything applying to adults or to children, and it really is just looking at young people aged 12 to 25. So if you don't have the time to go out there and search Google Scholar or one of those other forms, you can just log into the Orygen Evidence Finder. It won't block you, and again, it will at least give you the abstracts of the studies that you might be interested in. So that's all giving you a bit of a sense of what is the knowledge synthesis. How do I find the research evidence? How do I appraise it and judge whether it's good or not for your purpose? But let's now focus on the knowledge translation part, which is how do we apply that in a meaningful way in practice? And as you can see here, knowledge translation isn't just a static thing that we do for one topic, it's actually an ongoing process. So we're continually looking to update, collect more evidence, synthesize all of that. Then we do want to disseminate or push out that information, but even better would be if we're doing some knowledge exchange on this. So talking to young people or talking to other practitioners and clinicians about what this means and how useful you find it. And again, and importantly, applying that knowledge in an ethical way that improves the health and well-being of young people. And there's a quote here about fundamentally what we're talking about in youth mental health, that knowledge translation is simply all about how we deliver the best treatments or the best models of care or service, so we are improving the lives and the functioning of young people. Now, you might be confused by all of the terminology that's out there in this area, and we wouldn't blame you because different terms are used interchangeably. So that's where it might be research translation, evidence translation, knowledge translation. But then there's the terminology of implementation science. Sometimes these things are just used interchangeably, and that's okay. But what we are strictly speaking about with implementation is the how-to. So the knowledge translation might have identified the gap and figured out what's best in the context for you in your setting or for young people. The implementation science is the how we go about addressing that gap. And as I said, we won't get into that in today's webinar, simply because it's such a big topic that we'll be devoting more time to this in the coming months at Orygen. What are some of the methods of knowledge translation? Well, there's probably dozens and dozens. Some studies talk about there being almost 100 different ways that we can do knowledge translation. So this isn't exhaustive. We've just picked out here some of the main ones. So professional development is something that we as service providers do. Young people themselves will want to be involved in. It's how do we develop the knowledge and the skills in the particular area that we're interested in. And often in our area, there's some incentive or requirement to keep up PD. So you'll be earning points, for example. In medicine, they'll often refer to this as CME, or continuous medical education. Some different types of health practitioners, particularly more so in medicine, so GPs or psychiatrists, might run functions, dinners or lunches where they have an expert speaker come and talk about a particular issue, and that's the way of trying to translate knowledge to that particular group. Face-to-face training is a big one, and we'll pick that up when we look at the evidence for what works for these different activities in youth mental health. But this is something that we'd all be familiar with, going to a face-to-face training session to, again, try and learn something more about a topic. Webinars. So what we're doing today is a form of knowledge translation. Podcasts are a different way, depending on what's going to work best for the audience. Communities of practice is, again, really about this knowledge exchange of building a group of people who all have similar interests or similar passion about youth mental health, and how do they exchange and continue to adapt practice, often based on their own experience of doing this. And you can see some of the other examples that we've got there, including conferences are a form of translation, and even down to incentives, which we'll pick up as well. So as I said, this isn't meant to be exhaustive. This is just picking up some of the main ways that we do knowledge translation, but it can almost be anything that you're thinking about where you're trying to increase your knowledge and skills that will fall within this sort of domain. So we have the methods of doing this, then we have the levels at which we're trying to do knowledge transfer. And you can see here, often that's at the level of the individual clinician or service provider. So if you're doing a PD session, that might be focused on your individual level of trying to build knowledge. We can also have trying to do knowledge translation at a team level. So that might be all different psychologists or social workers or youth engagement experts in a particular area. Usually it's a team of different professionals, or it might just be a small team within a bigger organisation. And that's the third one there. We can also try to do knowledge transfer at the whole of organisation level, where everyone is included, not just the individual clinicians. Not surprisingly, efforts of knowledge translation that involve all three groups often tend to be the most effective, rather than just focusing on one particular area. And then let's not forget, if I drew another circle around all of this, there's the external environment, and that can actually affect knowledge translation as well. So what might be happening at a policy level could affect what we're trying to do here in terms of gaining more knowledge. So we'll focus on what's the evidence at these three levels, but it is important to be aware that in your area there could be lots of external pressures that are also influencing this. Okay, so what does the evidence say about what works for knowledge translation in youth mental health? You may not be surprised to hear that there's actually very limited research for knowledge translation in our area. So there's a body of evidence in medicine or health in general, but when we want to focus specifically on what's working in youth mental health practices, there's not a large amount of literature here. So again, scrutinise that and keep in mind that the evidence is really building, but it's not particularly strong at this point in time. What evidence does exist shows that there's no one strategy or approach that is consistently effective, that different approaches are likely to be effective in different contexts or with different groups. So let's examine in a bit more detail what that means. At the individual clinician level, there's evidence that ongoing processes that are providing feedback to clinicians do work at changing practice where clinicians are using the cutting edge research or best practice that's out there. You can see that there are a number of different ways that might happen. So it could be, there are studies showing that if you use reminders to clinicians about using evidence-based practice, that works. Feedback from young people or clients as to their progress and their updates help to shift clinicians to using evidence-based practice. What we call fidelity monitoring, that's where you actually look at the methods of applying a particular treatment and check, well, am I following these approaches? There's evidence that if individual clinicians do that, that again helps their practice. But it's really anything where we're just giving feedback to the clinician on how they're going. And I'll bring Carlo back in a moment just to talk about some of this, because this is obviously crucial from a young person's perspective. They want to be providing this feedback and having that exchange with their clinician or service provider, and the evidence shows that's a particularly strong way of using the best possible research. The second thing, and actually there's more evidence for this one than the first one, is that if we provide financial incentives to clinicians to use evidence-based practices, they're more likely to use them. I put that one second because I thought if you hear paying you to do evidence-based practice works, that everyone zones out on what are some of the other methods. But this is an interesting one, and you might have your own thoughts listening to this webinar as to what that means. But the evidence shows clinicians who are paid to implement the latest evidence do that, as opposed to clinicians who are not paid. So that's an interesting finding. If you think back to all of the different methods that we talked about for doing knowledge transfer, though, you can see that it is pretty limited at this point in time for what works at the individual clinician level. At the team level, there's evidence that workshops which are interactive and use adult learning principles are effective. So interactive as opposed to your classic didactic workshop where someone stands up and and delivers a whole lot of information and people ask questions. That's not effective. It's the very interactive workshops that have the best likelihood of changing practice at the team level. And adult learning principles are just making sure that this is goal-directed, that it's meaningful for the team and the practitioners there, that there's self-directed learning as opposed to just being pushed with information, again, in that very top-down way. And at the organisational level, there's evidence that basically changing cultures and structures within organisations can be effective at, again, changing practice towards using the most compelling evidence and knowledge. And you can see there's a framework that's been studied particularly in the US called the ARC framework. And that does have some strong evidence for changing practice. And what that's trying to do is instill in an organisation and a culture that people value innovation. They want to find the latest research. They want to do things in a new way. And again, that's often driven by young people saying, this is our preference for how you're doing things. But it's also focusing on a culture of quality improvement and effectiveness, or really what they're getting here is competency, that people actually can show that they are competent at what they're doing and not really just a bit stale in their work. So probably the strongest evidence does come from this organisational level approach, but as you can see, there are different things that work at different levels. And I might just stop there to bring Carlo back into the conversation, just for his perspectives and views on what all of this means, but particularly what this means at working with an individual clinician, with providing feedback or paying someone to use the best possible evidence.
Thank you, Rosie. What you were saying before about engaging young people in knowledge translation between the clinician and the young person is very important, because coming from my own perspective as a young person, being able to know what are the treatments available nowadays and having the choice to work together with the clinician empowers both the young person, but also it provides the clinician an understanding of where is the young person at, what's the type of treatment that would best suit them, and how can they work better together to make sure that this health alliance is healthy, but also effective for the care of the young person and the people around the young person. What I want to say to clinicians who are listening is really listen to what the young person has to say and try to gauge how the young person want to be involved in. There isn't like a perfect way, but asking and checking in regularly whether the young person is happy about this treatment style, whether it's working, so that you get feedback in real time and you both, the young person and the clinician, can work together in delivering an appropriate care.
Thanks, Carlo. I think that's really invaluable, a really invaluable perspective on all of this. And as a clinician researcher myself, that message of just check in. There'll be different ways that young people want to provide feedback. There's no one-size-fits-all approach. But as we can see here, the evidence suggests that that is one of the strongest ways that you can be using evidence in practice and doing that in a way that's likely to have better outcomes for young people. What does the research say doesn't work? Well, interestingly, one of the most common methods for knowledge translation is to provide teams with educational content, either in the form of written material, handouts or guides, or via workshops. And interestingly, the evidence currently shows that brief didactic workshops, so whether these are half a day or 1 day, do not make much difference to meaningfully changing clinical practice, nor does just providing a written handout. And I'm sure for the clinicians and service providers who are watching this webinar, that will resonate with you, that simply that dissemination of writing and putting stuff out there isn't meeting your needs for how to best change practice. So we do have to be very mindful about what is working and what's the way that's going to be most responsive to clinical practice in the real world. So again, you can be out there now as scrutinising your own professional development and trying to make sure that things are as interactive, based on adult learning principles, so that it is meaningful to you rather than just this one-way push of information. What does all this mean in practice? What does evidence synthesis and knowledge translation actually mean in practice? And just to summarise from today, I think the information that we've heard, and certainly Carlo's perspective as a young person and a young person involved in research through the Youth Research Council at Orygen, it shows that clinicians and services cannot afford to ignore knowledge translation. This is the way that we identify the whys, why are things affecting particular young people and not others, and the how. How can we better change our practice or better change our model of care to make sure that this is improving outcomes for young people. The second thing to take from today's webinar is this knowledge that there's not a single effective knowledge translation method, but mostly this will be effective if it's applied at different levels. So taking into account what's likely to work for individual clinicians, and we can see there it is incentives or feedback, what's most useful for teams, and what's most useful for organisations. Now, in the real world, all of those things may not be able to be addressed in knowledge translation, but if we are thinking of, well, how will we try and change practice, whether you're doing this as an organisation or as a passionate service provider, be mindful that the more levels that you're looking at, the greater likelihood that you're infusing your whole culture with the importance of knowledge translation. The third thing is that knowledge translation is an ongoing process. As we've said, it's not providing a workshop, it's not providing handouts, it's not doing today's webinar. It's about an ongoing interactive and exchange process. So it is helpful to do educational work, but where the rubber really hits the road is where you're sharing and exchanging that knowledge with your colleagues, engaging young people as part of this conversation, informing research as to what are the critical questions from your perspective as clinicians and service providers, And if we think back to that original diagram of the research cycle, actually connecting all of that up. So the knowledge translation does inform the next series of questions. So we're continually building our knowledge. And we talk a lot about the word innovation, but that's, I think, where innovation genuinely comes alive. It's following up all of these questions and being curious as to how can we do things better? How can we do things in a way that's going to have the most impact on young people's lives? And the last thing that we'd like you to take out of today's webinar is this notion that knowledge translation does have to be adapted to your particular context, or to the preferences of the young people that you're working with. So what that means in youth mental health, for example, could be that you take some knowledge and information that's out there. It might have been delivered to you at a workshop, but that's where think about, how would I apply this if families are involved? Or how would I apply this given the developmental age of the young people that I'm working with? What you might be doing with a 14-year-old could be very different, obviously, with a 23-year-old. Or how do I adapt this for the young people in our service who are culturally and linguistically diverse or sexually diverse? So that's what we're really wanting you to take from today's webinar as well. Be critical appraisers of evidence, but then always think, how do I apply this in my particular context? And that's where we get to the heart of knowledge translation in practice. So we'll end it there, and thank you for your time. If you do want to know more, one of the best sources of information is the Canadian Institutes of Health Research. They've led the way internationally for knowledge translation as well as implementation science. And their website, if you Google that, provides a wealth of information if you are interested and curious to look at this a bit more. But I'll also stop and leave the final word for Carlo, just to again give a reflection on what all of this means to young people who might be engaging with you or using your services. So thanks for your time today, and over to you, Carlo.
Thank you, Rosie. Thank you for listening to today's webinar. As Rosie was saying, it is very important that we can relate to young people when we provide treatment and services in youth mental health. Being able to engage with young people is key in today's service and for future services in mental health. Why? Because engaging young people means respecting their individuality, and also being able to listen to what are their needs. So next time, just have a conversation with the young person, listen to what they have to say, and just check in if the type of treatment that you and the young person you're working on is working well or not. This will make a whole difference in the recovery process for the young person. Again, thank you for your time, and we look forward to seeing you at the next webinar.